All right, welcome back to the deep dive. Today, we're going deep, really deep into something pretty critical when it comes to surgery.
Definitely vital.
How to feed people, right?
Yeah, surgical nutrition. It's a big one.
Huge.
Yeah.
And we've got the Espen practical guideline, which, it's kind of like the European gold standard.
It's in the Bible over there.
Yeah.
Yeah.
Yeah. And we're trying to pull out the most important things. Like if you don't have time to read this whole thing, we're going to give you the shortcut to being well informed.
Absolutely. Distilling it down to the must-knows.
Must knows. We want to understand, like, the current best practices. How has this changed recently, and how do we make sure that patients recover faster and better?
Right, because the goal is always better outcomes for patients.
Exactly. And
Yeah.
so let's start with something that might surprise you, something you've probably heard for years,
Okay, I'm intrigued.
that you need to fast before an operation, right?
Yeah, nothing by mouth after midnight. That's the classic.
Absolutely. But guess what? That's not necessarily true anymore.
Oh, what's changed?
Well, the very first recommendation in this guideline
Okay.
challenges that. So for most people, that whole long fasting period, unnecessary.
Really? So are they saying we can eat right up until the surgery?
Not quite. They say clear fluids are fine up to 2 hours before anesthesia.
Interesting.
And you can even have solid food until about 6 hours before.
So no more midnight cutoff. That's a big shift.
It is. And there's science to back it up. They've looked at the evidence, no increased risk of aspiration or regurgitation with these shorter fasting times. And they explain why. Clear fluids, they empty out of your stomach pretty fast, like within 60 to 90 minutes. There are a bunch of studies they cite, numbers 12 through 14 in the guideline.
So it's about what you're consuming, how quickly it moves through your system. Makes sense.
Right. And this fits in perfectly with what they call ERAS, enhanced recovery after surgery.
Oh, yeah, I've heard of that, getting people back on their feet quicker.
It's exactly.
Yeah.
Less time in the hospital, fewer complications. And think about it from the patient's perspective. You're not as thirsty, not as uncomfortable. You're less likely to get a caffeine withdrawal headache if you're a regular coffee or tea drinker, because those are clear fluids, by the way.
Right, and no one wants a headache on top of surgery. But I'm guessing there are exceptions to this.
Of course, it's not a blanket rule. So patients with specific risks, like those having emergency surgery or people who have problems with their stomach emptying slowly or reflux, they might still need to fast longer.
That's logical. Certain situations call for different approaches.
Absolutely. And, it makes you wonder, with these more relaxed guidelines, have there been more complications?
That's a good question. Has aspiration gone up?
Surprisingly, no. The guideline specifically mentions there hasn't been a dramatic increase in aspiration since these recommendations came into practice.
So the science seems to be holding up in the real world. That's reassuring.
Right. So we talked about when you can eat before surgery, but now let's get to recommendation number 2, which is kind of proactive.
Okay, proactive in what sense?
So instead of just saying don't eat, this guideline suggests we actually give patients a carbohydrate drink before their operation.
Interesting. So we're actively providing nutrition leading up to the procedure.
Yeah. And the idea is that it helps reduce discomfort around the time of surgery, might impact how your body handles insulin, and maybe even shorten your hospital stay, especially for major surgeries. They give this a B recommendation, meaning there's some good evidence, but more research is needed.
So what does this carbohydrate drink look like? Just a sugary beverage?
Not exactly. They recommend about 800 milliliters the night before, and then another 400 milliliters 2 hours before you go in for surgery.
Okay, so it's pretty specific. And what kind of drink are we talking about?
Well, they even mentioned fruit-based lemonade as a safe alternative, which is interesting.
Lemonade. So it's not just pure sugar then?
No, and the research suggests it empties from the stomach at the same rate as other clear fluids.
That's good to know. I mean, dumping a load of sugar into your system right before surgery doesn't sound ideal.
Right. And there are reported benefits, improved well-being after the surgery.
So patients just feel a bit better overall?
Yeah, it seems like it.
Yeah.
But when it comes to the length of hospital stay, that's where the evidence gets a bit more murky. There are some big reviews that suggest it might help, especially after major surgery, but others don't show a clear impact.
I see. And are they looking at complications too?
Some of them are, yeah, but there's no consistent finding on that. And there's a bit of a problem with blinding in these studies.
Oh, right, because it's hard to mask whether someone's drinking a carbohydrate drink or just water.
Exactly. And the guideline mentions a recent large study that looked at this, and it found that people who had the carbohydrate drink needed less insulin and had lower blood sugar levels after surgery.
Okay, that makes sense. But did it translate to better outcomes?
Well, that's the thing. It didn't actually change the number of clinical complications. So it might influence some things, like metabolism, but the effect on bigger complications isn't a slam dunk.
I see. So it's promising, but more research is needed to see the full picture.
Exactly. And just like with the fasting guidelines, this isn't for everyone.
Right. There are always exceptions.
So this carbohydrate loading isn't recommended for patients with severe diabetes or those who are known to have gastroparesis, which means their stomach empties really slowly.
Okay, makes sense. So moving on from what happens before surgery,
Yep.
let's talk about what happens after.
Okay, so recommendation number 3 is pretty straightforward. In most cases, you should just continue eating and drinking as normal after surgery.
Really, no break for the digestive system.
Nope. That's a big change from how things used to be. Like, we used to think that your gut needed to rest after an operation.
Yeah, I remember hearing that too.
But the evidence just doesn't support that anymore. Getting back to eating and drinking, it's a key part of this ERAS thing we were talking about, enhanced recovery after surgery. And studies have shown that it's linked to fewer complications, and you get to go home sooner.
Shorter hospital stay, that's always good.
Right. And they even looked at things like, remember we talked about using a tube to drain the stomach after surgery,
Yeah.
or delaying when you can start eating.
Yeah.
So they looked at those things even after common operations like removing the gallbladder or bowel surgery, and guess what? None of it was shown to be helpful.
Interesting. So less is more in this case.
It seems like it. Our understanding of how the body heals has really advanced.
Right, we're constantly learning new things.
Absolutely. But there's a bit of a caveat here, because recommendation number 4 says that you need to adjust what you eat and drink based on how you're feeling and what kind of surgery you had. And they say to be extra careful with older patients.
That makes sense. One size doesn't fit all when it comes to recovery.
Exactly. So while early eating is generally good, you need to be smart about it. For example, the guideline talks about how people often tolerate food sooner after keyhole surgery on the colon compared to open surgery.
Makes sense. Less invasive procedure, probably faster recovery of bowel function.
Right. But then they say that if a full ERAS program is in place, that difference between keyhole and open surgery kind of disappears.
Interesting. So the overall approach to recovery plays a big role.
It does. And when you combine ERAs with keyhole surgery, you get a shorter hospital stay and fewer major complications.
That's a winning combination.
Definitely. Okay, recommendation number 5 really pushes this early eating thing, saying that for most patients, you should start eating and drinking, even if it's just clear liquids, within hours after surgery.
Wow, so we're talking really early here. Is there strong evidence for this?
Yeah, they give this an A recommendation, which means there's a lot of good quality evidence supporting it. So starting on normal food, or EN, that's enteral nutrition, basically feeding through a tube, including clear liquids. If within a day or 2 after surgery, it doesn't mess with the healing of your anastomosis, which are those surgical connections in your gut.
Good to know those connections are safe.
Yep. And not only that, it actually shortens your hospital stay significantly. They cite a whole bunch of reviews and studies that all point to this.
So the evidence is pretty solid on this one.
It is. And it's not just one type of surgery either. They talk about positive outcomes after big operations like a total gastrectomy.
Removing the stomach entirely.
Yeah, minimally invasive esophageal surgery, and even general upper GI surgery, all without increasing the risk of leaks.
Wow, so it's applicable across a wide range of procedures.
Seems like it. All right, let's shift gears a bit now.
Okay, where are we headed?
So when do doctors need to think about formal nutritional support, like feeding tubes or IV nutrition?
Right, when does it become necessary to go beyond regular food?
Recommendation number 6 stresses how important it is to check the patient's nutritional status before and after major surgery.
Makes sense. You need a baseline, and you need to see how the surgery might affect their nutrition.
Exactly. The guideline says that if someone can't eat properly for more than 14 days, it's linked to higher mortality.
Oh, wow. That's significant.
And tons of research shows that being undernourished makes complications more likely. You stay in the hospital longer and the costs go up. This applies to all patients, but especially those having cancer surgery.
So it's not just about whether someone is visibly underweight.
No, it's about understanding their overall nutritional status and how well they're able to eat.
Right. So what are the specific situations where they recommend nutritional support?
Well, recommendation number 7 outlines that. So if a patient is malnourished or at risk of becoming malnourished, If they can't eat for more than 5 days around the time of their surgery, or if they're only eating less than half of what they need for more than a week, then the guideline says start nutritional support.
Okay, so those are the red flags, so to speak. And what's their preferred method for providing that support?
Preferably through the gut, so oral supplements or a feeding tube.
Makes sense. Utilizing the natural pathway whenever possible.
Right, unless there's a good reason why you can't, like a blockage or the patient is in shock. And they really emphasize doing this early.
Really mean it.
Like within the first 24 hours, there's a bunch of research showing that starting EN early is better than waiting.
So it's not just about giving support, it's about the timing, too.
Exactly. And even for critically ill patients in the ICU, guidelines recommend starting within 48 hours.
So there's a real push to get nutrition in as soon as it's safe and feasible.
Absolutely. Now, what if someone just can't get enough through eating or a feeding tube?
Yeah, what are the options in those situations?
So recommendation number 8 addresses that. It says that if someone's getting less than 50% of their needs met for more than a week through eating or a feeding tube, then you should consider combining tube feeding with IV nutrition.
Okay, so it's sort of like a dual approach to make sure they're getting enough.
Exactly. And if the gut's completely out of the picture, then they say to start 5E nutrition ASAP.
Makes sense. You got to get those nutrients in somehow.
Right. They also talk about the debate between feeding through the gut versus 5E.
Oh, yeah, I've heard about that. What's the latest on that?
So EN, that's enteral feeding, is generally better for things like infections, preventing leaks from the surgical connections, and shorter hospital stays after bowel surgery, although they haven't really seen an impact on mortality.
But EN isn't always an option.
Exactly. Sometimes it's just not feasible or tolerated, especially right after surgery. And IV nutrition might be the way to go, especially if the patient is undernourished and their gut isn't working properly, or if they have complications that stop their gut from functioning for more than a week.
Okay, so those are the situations where IV nutrition might be more beneficial.
Right. They also mentioned that some patients might not tolerate full tube feeding right after surgery, and the jury's still out on whether chewing gum actually helps the gut recover faster.
Chewing gum, that's a weird one.
I know, right? And then there's the issue of severe trauma patients. They might struggle with tube feeding in the early stages.
So lots of factors to consider when deciding the best route for nutrition.
Absolutely. So when it comes to giving IV nutrition, recommendation number 9 has a clear preference. They recommend using all-in-one bags, either the 3-chamber ones or those that are prepared by the pharmacy.
And why is that? What's wrong with the old multi-bottle systems?
Well, research has shown that the all-in-one bags are more cost-effective, and an analysis of U.S. hospital data suggests they might have a lower risk of bloodstream infections.
So it's about efficiency and safety.
Exactly. And to make sure that nutritional support is as effective as possible, they stress the importance of having SOPs.
SOPs, you mean standard operating procedure?
Yes. And they're recommended for effectiveness, to make sure everyone's on the same page.
Right, because consistency in care is crucial.
Exactly. And having clear feeding protocols and SOPs has been shown to improve both safety and how well we meet the patient's nutritional goals.
It makes sense to have standardized guidelines in place.
Now let's talk about specific supplements.
Getting into the nitty-gritty.
Recommendation number 11 looks at giving the amino acid glutamine intravenously. They say that it might be considered for patients who are getting all their nutrition through IV.
So supplemental glutamine in specific cases, what's the reasoning behind that?
Well, there have been a lot of studies on glutamine, especially in critically ill surgical patients who are relying on IV nutrition. But a big study in well-nourished patients having major bowel surgery didn't show any benefit in terms of complications or length of stay.
So mixed results.
Yeah, some reviews suggest it might help with infections and shorten hospital stays, but a recent study in ICU patients didn't find any difference in mortality or infection rates.
So not a clear-cut winner.
No, not yet. And they point out that most people don't need IV nutrition for more than 5 to 7 days after straightforward bowel surgery anyway. Plus, there isn't much data on what happens when you combine IV glutamine with regular eating or tube feeding.
Okay, so more research is needed before they can make a strong recommendation.
Exactly. And interestingly, there's no clear recommendation for taking glutamine by mouth either, because we just don't have enough research on that yet.
That's surprising. You'd think there'd be more data on oral supplementation.
You would, but there isn't. Okay, moving on to another amino acid, arginine. Recommendation 12 says that we don't have enough evidence to recommend giving arginine alone, either through FOV or a feeding tube.
So arginine is more of a question mark at this point.
Yeah, the information is limited. They do mention one review of studies in head and neck cancer patients that suggested giving arginine through a feeding tube around the time of surgery might reduce leaks and shorten hospital stays.
Okay, so some potential there, but not definitive.
Right. And there's this long-term study that suggested better survival in head and neck cancer patients who had more arginine in their diet. But that study had its limitations.
So more research is needed to confirm those findings.
Definitely. All right. Recommendation number 13 focuses on omega-3 fatty acids in IV nutrition. They say that giving omega-3s through 5E after surgery should only be considered for patients who can't eat enough and need IV feeding.
So omega-3s are specifically for those who are completely reliant on IV nutrition.
It seems that way. A lot of reviews have suggested that omega-3s might reduce infections after surgery and shorten hospital stays, but the guideline points out some issues with how those studies were done,
Like what kind of issues?
like how they defined infections and the variation in length of stay. One review even found no significant difference with a newer type of fat emulsion.
Okay, so the evidence isn't as strong as we might like it to be.
Right, and they highlight that most of the patients in those studies weren't just on IV nutrition, so it's a weak recommendation because of those methodological issues.
I see. So more work to be done on clarifying the role of omega-3s.
Exactly. And the benefits of giving omega-3s through IV for a short time around surgery need more research too. Now, recommendation number 14 brings us to specific formulas that are enriched with arginine, omega-3s, and ribonucleotides.
So we're talking about those immune-boosting formulas.
Yep. And the guideline recommends giving those around the time of surgery to malnourished patients who are having major cancer surgery.
Okay, so a targeted use for these formulas.
Right. But there's no clear evidence that using these formulas alone before surgery is better than standard oral nutritional supplements.
So there's some nuance there.
Definitely. But there's a lot of interest in these formulas, and many reviews suggest they can help reduce complications and shorten hospital stays, especially when they have all three arginine, omega-3s, and ribonucleotides.
Makes sense. It's like giving the immune system an extra boost.
Right. And the timing, whether to give them before, during, or after surgery, is still being debated. But they've shown benefits after major abdominal cancer surgery, particularly in those who are malnourished.
So for specific cases, these formulas seem promising.
Yeah, and one review actually found a significant difference in infections and length of stay only when comparing preoperative immune nutrition to a standard diet with no supplements.
That's interesting. Suggesting that there might be an advantage to starting them before surgery.
It seems that way.
Yeah,
And it's been noted that they can be cost-effective too.
that's always a plus.
Definitely.
Yeah.
Okay, moving on to nutritional therapy before surgery in general.
All right, what are the recommendations there?
Recommendation number 15 is pretty clear. Patients who are at severe nutritional risk should receive nutritional therapy before major surgery, even if it means delaying the operation.
So prioritizing nutrition even if it means adjusting the surgical schedule.
Yep, and that includes cancer operations. They even say that 7 to 14 days might be a good time frame.
So taking the time to get them nutritionally optimized?
Exactly. And defining severe nutritional risk is important. They refer to specific criteria like significant weight loss, low BMI, certain scores on nutritional assessments, or low levels of albumin in the blood.
Right, so it's not just about being thin, it's about a whole range of factors.
Absolutely. And, low albumin, it's a risk factor for surgery, but it can also just reflect how sick someone is.
So it's not always a straightforward marker of nutritional status.
Right. But recent data still highlights the importance of albumin levels.
Okay, so it's complex. But what about the benefits of this preoperative nutritional therapy?
So the benefits of giving nutritional support before surgery to those who are severely undernourished, they're well documented, lots of research supports it, and it seems to be particularly good at reducing complications after surgery.
So it's not just about feeling better, it's about tangible improvements in outcomes.
Exactly. And they suggest that giving support for at least 7 to 10 days is important. One study even showed significantly fewer surgical site infections in stomach cancer patients when they were well nourished for at least 10 days beforehand.
Wow, that's a big difference.
It is. They also mentioned this thing called trimodal prehabilitation.
Trimodal prehabilitation, what's that?
So it combines nutritional support with exercise and psychological support for a few weeks before surgery.
Interesting. So a holistic approach to getting ready for surgery.
Yeah, and it's for high-risk patients. And recommendation number 16 emphasizes that whenever possible, we should try to use the oral or enteral route for this preoperative support.
So eating or using a feeding tube if necessary.
Right. Getting a dietitian involved early is really important, especially for cancer patients who are having multiple types of treatment. And if someone needs IV nutrition, like if they have a blockage in their upper digestive system, it should be combined with eating whenever possible.
Makes sense to use all available avenues to get them nourished.
Exactly. And they warn about something called refeeding syndrome, which can happen in severely malnourished patients when you start feeding them again.
Oh, right. That can be dangerous if not managed properly.
Definitely. And one study that compared giving nutrition before surgery through a tube or through IV based on their risk score, it found that the patients with a higher risk score who got preoperative nutrition did much better.
Fewer complications and shorter hospital stays.
Yep.
Okay, so preoperative nutrition really does make a difference.
It seems like it, especially for those who are at higher risk. Now, let's focus on oral nutritional supplements, or ONS, and enteral nutrition, or EN, before surgery.
All right, breaking it down further.
So, recommendation number 17 says that we should encourage ONS for patients who aren't meeting their energy needs, regardless of whether they're officially malnourished or not.
So if they're not getting enough calories, give them supplements.
Yep. Even if they're not technically undernourished, if they're not eating enough, those supplements can help. And they specify that we should use standard balanced formulas that meet European regulations.
Okay, so quality control is important.
Absolutely. Now, some studies on ONS in general, surgical patients haven't shown major benefits when they've done these big reviews. Well, I think it might be because many of the patients in those studies weren't at high nutritional risk.
Ah, so the benefits might be more pronounced in those who are already struggling.
Exactly. But one study did find fewer minor complications, and another showed that ONS helped prevent weight loss after surgery when they continued using it.
So there are definitely some benefits to be had.
Right, especially for those who are losing weight. And they've also shown that standard ONS is cost-effective.
That's always good to hear.
Definitely. Okay, recommendation number 18 gets a bit more specific, saying that ONS should be given before surgery to all malnourished cancer patients and those at high risk who are having major abdominal surgery. And they point out older adults with sarcopenia, which is basically muscle loss, as a particularly high-risk group.
So again, focusing on those who are most vulnerable.
Exactly. And this links back to those earlier recommendations about identifying and supporting high-risk patients.
Right, it's all connected.
It is. Now, recommendation number 19 suggests that immune-modulating ONS, those ones with arginine, omega-3s, and nucleotides, can be considered and given for 5 to 7 days before surgery.
So those specialized formulas might have a role to play in the preoperative period as well.
It seems so. And they emphasize the importance of making sure patients understand why they need to take these supplements.
Right, because compliance is key. If they're not taking them, they're not going to get the benefit.
Exactly. And ideally, this all starts before they even come into the hospital.
To minimize unnecessary hospital stays and reduce the risk of infections.
Absolutely.
Okay.
Okay, last one for preoperative nutrition. Recommendation number 20 talks about IV nutrition before surgery. They say it should only be given to patients who are malnourished or at severe nutritional risk and can't get enough through eating or a feeding tube. They recommend 7 to 14 days.
So IV nutrition is reserved for those who really need it.
Yeah, it's not a first-line approach. And there's good evidence to support this. They've seen benefits in patients with significant weight loss before major bowel surgery. One study even showed 30% fewer complications and reduced mortality with 10 days of IV nutrition before and 9 days after surgery.
That's pretty impressive.
It is. Now, some guidelines recommend 7 days, but this expert group thinks that 10 to 14 days is better for those at high nutritional risk.
And they have the research to back that up.
Yep, a review of the research showed that preoperative IV nutrition significantly reduced complications.
Okay, so longer duration seems to be better in certain cases.
It seems that way. All right, let's move on to giving nutrition through a feeding tube after surgery.
Sounds good. What do they have to say about that?
So, recommendation number 21 says that early EN, within 24 hours, should be started if someone can't eat enough by mouth and is likely to have inadequate intake for more than 7 days.
So early intervention with tube feeding if needed.
Exactly. And this is especially important for patients having major head and neck or bowel cancer surgery, those with severe injuries like brain injury, and those who were already malnourished when they had their operation.
Makes sense. Those are all situations where getting adequate nutrition is going to be particularly challenging.
Right. And there's new research supporting this. It's safe to start eating by mouth very soon after certain operations, like a partial or total gastrectomy, minimally invasive esophageal surgery, and total laryngectomy.
So the trend is definitely towards earlier feeding whenever possible.
It is. But these patients we're talking about, they often have low nutritional reserves to begin with, and they're at higher risk of infections. Plus, problems after surgery can delay when they can start eating normally.
So early tube feeding can really bridge that gap and make a difference in their recovery.
Absolutely. And it's been shown to reduce complications. Early tube feeding in trauma patients is linked to fewer infections and might even reduce the risk of multiple organ failure if started within the first day.
So those are some pretty compelling arguments for early intervention.
Definitely. And in patients with head injuries, early feeding might lead to fewer infections and better outcomes.
So it seems like early nutrition is beneficial across a wide range of patient populations.
It really does. Okay, recommendation number 22 talks about the type of formula we should use for tube feeding, suggesting that a standard formula with whole proteins is fine for most patients.
Makes sense. Keep it simple unless there's a specific reason to do otherwise.
Right. And they generally don't recommend homemade diets for tube feeding because of the risks of contamination and technical issues.
Yeah, you don't want to be messing around with homemade concoctions when it comes to feeding someone through a tube.
Definitely not. Although they do say that homemade diets might be considered in home care settings.
Okay, so there's a bit of flexibility there depending on the circumstances.
Right. And as for those immune-boosting formulas, we need to go back to recommendation number 14.
Right, those are reserved for specific cases. Now, what about the actual method of delivering tube feeding after surgery?
Recommendation number 23 suggests considering a nasogeneral tube, which goes through the nose into the small intestine for all patients needing tube feeding after major upper GI and pancreatic surgery, especially if they're malnourished.
So, a more targeted approach to tube placement.
Exactly. And there's research showing that this can be beneficial and is feasible.
Okay, so it's not just theoretical, it's actually being done.
Right. Now, some might argue that routinely using these tubes is overkill, but they have shown benefits in procedures like esophageal resection with low complication rates.
So, for certain surgeries, it seems to be worth considering.
It does. One study in patients having pancreatic surgery didn't find a big difference in complications, but they did see shorter hospital stays with these tubes.
Interesting. So, it might not prevent complications, but it could help people get out of the hospital sooner.
Right. However, a review of studies didn't strongly favor tube feeding over IV nutrition in this setting.
So, the jury's still out on whether it's always the best approach.
It seems that way. And they mentioned that these nasogeneal tubes can sometimes get accidentally dislodged.
Oh, right. That's a problem.
Yeah, so some experts think that placing a feeding tube directly into the small intestine during surgery might be a better option for patients at high nutritional risk.
Makes sense. More secure placement, less chance of interruption.
And it could be continued after they go home.
So it offers more flexibility and continuity of care?
Exactly. Okay, recommendation number 24 is pretty straightforward. Tube feeding should be started within 24 hours after surgery. And then number 25 advises starting with a low rate and increasing it gradually because the intestine might not tolerate it well at first. It could take 5 to 7 days to reach the full target.
So a start low and go slow approach.
Pretty much. And they emphasize the importance of close monitoring, especially if there are issues with the digestive system.
Right, because you want to avoid causing any further problems.
Absolutely. And you can't just pump in the nutrition as fast as possible. They warn about the risk of ischemia, which is reduced blood flow to the small bowel if you increase the rate too quickly.
So careful titration is key.
It is. Okay, for patients who need tube feeding for a long time, like more than 4 weeks, recommendation number 26 suggests considering a PEG tube.
A PEG tube, that's the one that goes directly into the stomach through the skin, right?
Yeah, and they say to consider this, especially when abdominal surgery isn't otherwise indicated.
So if they don't need to be opened up for another reason, a PEG tube might be a good option for long-term feeding.
Exactly. Now, for blockages in the upper digestive system before surgery, whether to place a PEG tube is up to the surgeon. But general guidelines for PEG tubes recommend them for feeding that's expected to last at least 2 to 3 weeks.
Okay, so there are specific indications for when a PEG tube is most appropriate.
Right. Now, looking at the period after surgery and going home, recommendation number 27 says to regularly check the patient's nutritional status while they're still in the hospital.
Makes sense. You want to make sure they're on the right track before they leave.
Absolutely. And then they say to continue support and dietary advice after they're discharged if they're still struggling to meet their nutritional needs by mouth.
So it's not just about getting them through the surgery. It's about ongoing support to ensure they're properly nourished at home.
Exactly. Patients who have complications after surgery can still lose weight, and a nasogeneral tube can be useful for providing extra nutrition at home after discharge.